screen. Here we are. So that's me. And I have no disclosure to report. You've been aware, I believe, in other presentation about the potential bias, and the objective for today are to first distinguish the categories of BPSD, their characteristics and their impact on the resident and their relatives, which I'm sure you're very aware of. To describe the general clinical process for evaluating BPSD and choose the most appropriate intervention to attenuate BPSD. So first, when I'm in front of someone, well, for a consultation about BPSD, my first reflex is trying to describe very precisely what is the behavior, because I believe that when you understand some behaviors as clusters, you can find some explanations about etiologies and also build a more specific intervention plan. So in my clinic, I used to distinguish between affective symptoms, mostly depression, anxiety, maybe we can put apathy there, psychotic symptoms, neurovegetative symptoms, and symptoms or behaviors that are more associated with the frontal lobe dysfunction. As you know, the frontal lobe is responsible for being able to adapt our behavior in social context and to inhibit some very impulsive actions. So when it becomes less functional in dementia, we see appearing some repetitive behaviors or vocalization or disinhibition, either aggressive or sexual or verbal, and also some primitive behaviors or reflex that we can see also in newborns, which are in that case signs of an immature frontal lobe, but in dementia it's more degeneration, like imitation behavior, utilization behavior, or the grasp reflex. Just a little illustration of that kind of behavior, repetitive movement behaviors. I'm showing this video because it introduced the fact that some behaviors won't respond to medication. So using a medication, having the reflex to give, let's say, alloperidol or Ativan to that kind of patient would be just like putting a chemical restraint, and it's not good practice. It's not recommended. So those kinds of symptoms are more easily treated with non-pharmacological intervention, but they need to be individualized. Like in this case, this man used to be a landlord, so I give him a set of keys. And afterward, when we learn a bit about his interest and his life history, we knew that he had a dog, which he liked very much. And you can see that for many minutes, even hours, it can stop the behavior. And then the other residents are less irritated by that repetitive movement, and we would be able to avoid giving some medication. So it's just an illustration of some frontal lobe behaviors. If we look at epidemiology, we know that in some reports, even all of Alzheimer's patients or related dementias will suffer from BPSD at some point in their disease. It could be either apathy, which is very frequent to psychotic symptoms. And those behaviors or psychological symptoms are associated with faster cognitive and functional decline, with higher risk of institutionalization. I'm not even able to say it in French, so okay, you know what I mean. Increased mortality, decreased quality of life, increased caregiver burden, increased use of physical and chemical restraints, and of course, cost for the health system. So they have major impact. The approach to evaluate a symptom like that, I like the DICE approach. If some of you are aware of this approach, it's been published a few years ago. DICE for first describe precisely what is the behavior or the symptoms that the patient is showing. Then investigate the possible etiologies, then create an intervention plan, and then evaluate the intervention plan and see if it needs to be readjusted. I know that in Canada, you've been trained with the PIECES approach, which is a way to investigate possible causes for behavior. Pieces for physical, often unmet basic needs are at the roots of BPSD, but also some medical conditions, medication that can give side effects, behavior side effects, also intellectual causes related to the dementia per se, emotional, the capabilities that are challenged in an environment that is less understandable for patient, environmental causes, social causes. So one needs to be able to evaluate for every causes of behaviors that could be then put into the intervention plan. There are three types of intervention then if we try to build a plan, either pharmacological, environmental, or non-pharmacological. Again, in every guidelines here, I've put some sentences from the CCSMH guidelines or the CCD, and also every international guidelines continue to emphasize the need to rule out first underlying medical problems that could be at the root of those behaviors, and also the need to use first psychosocial or non-pharmacological interventions prior to use medication. Why? Because there are some BPSD that are not likely to respond to medication. And here you will recognize the frontal lobe behaviors that I've described earlier. So if you prescribe something for that kind of behavior, it's again like a chemical restraint. So you will be only sedating the patient, and the burden of side effects is usually higher than the benefit from prescribing. So one needs to be a bit creative in addressing those behaviors that could be very disturbing in a long-term care environment mostly, but still refraining from prescribing should be the first reflex. The BPSD that may respond to medication are first anxiety or depressive symptoms, but then we would use mostly antidepressant medication. Some sleep disturbance, there's no very big double-blind studies about that, but there's some evidence for low-dose trazodone, manic-like symptoms or delusion or hallucinations, which then would be treated with antipsychotic medication, severe verbal and physical aggression, and possibly sexually inappropriate behavior. There are many kinds of non-pharmacological intervention, one needs to be creative and try to individualize the intervention to the patient. But in the literature, we know that staff education programs and caregivers psychoeducations are the first step in trying to lessen the problematic behavior, because often it's related to the way people interact with dementia patients. There is also basic approaches how to look, to talk to patients with dementia. Basic strategies like diversion, for example, very efficient with resistiveness of care, for example. Also environmental interventions to try to build an environment that is comprehensible for the patient. And finally, more complex non-pharmacological structured intervention. For staff education, you have some reference here of either, this one is in French, the other in English, about some program that could be useful. Caregivers psychoeducation, I put some that I'm aware of for caregiver support about PTSD. Then if we look at environmental intervention, some specific aspect to consider are, well, first, the level of stimulation, either visual or auditive, to hide unhelpful stimuli, to give some temporospatial orientation cues, and also to personalize the space. Here are some examples. Some people that live still in very institution-like facilities with, long corridor where they wander and then they enter into the last room. Hopefully there's no aggressive patient in that room, because then it produced such a fight. But if the space is built in a more home-like aspect, then it could help decreasing some behaviors. When I'm talking about hiding unhelpful stimuli, here you see the elevator, which is very, very visible, and it's been discreetly hidden with some beautiful design. So then the patient are less at risk to take the elevator and run away. Having an outdoor space where wandering could be used as a therapeutic activity, and also being able to be in contact with nature is very important. And then when we look at more structured non-pharmacological interventions, basic objectives are first to, they need to be individualized to the life story and the interest of the subject. They need to be utilized also strategically to prevent BPSD at problematic time of the day. With my video, we use those intervention at some times of the day when we know it would be very problematic on the ward. Let's say when there is a change of staff at specific hours, then that intervention could prevent the escalation of behavior and response from other residents. They need also to be based on residual capacities. And we know that in Alzheimer's, at least, the capacities that stays longer are long-term memory. So with reminiscence therapy, for example, we use that residual capacity, procedural memory, affective memory, or sensorial memory with all the sensorial intervention that could be proposed. So there are many type of non-pharmacological intervention, and it's a bit of a challenge, but it's good to be able to use our creativity and to try some intervention and see if they are adapted to a specific individual. So this is for non-pharmacological. If we get into medication now, as I've said earlier, we know that the indications are for behavior of moderate or severe intensity that poses a health or safety risk for the patients or others, because the benefits of the pharmacological treatment needs to outweigh the risk. There are general principles in geriatric medicine that you are aware of. We always start at low doses. We go slow, but sometimes we need to go at higher dose to have the best benefit we can get. We need to use one pharmacological agent at a time, because if I prescribe 2 medication and withdraw 1, I don't know what's happening. Is it a side effects of the new ones? Is there withdrawal from the others? So one change at a time. Check often for side effects. Those patients are very fragile to side effects. Complete response can take 2 to 6 weeks. One need to consider changing agents if there is no efficacy that shows itself. Because if you just had some medication, then you're just stuck with a polypharmacy with many medication that are not efficacious. So switching from one inefficacious to another one that could be more efficacious is the best way to do it. And all the guidelines recommend in BPSD to attempt progressive withdrawal after the patient has been stable for 3 to 6 months. There are some exceptions to that. Very severe behaviors, or it's more difficult to withdraw, or if there is some comorbidities with chronic anxiety or depression, then maybe you need to pursue the medication. Here are the drug classes used in BPSD. You're aware that antipsychotics are used, antidepressant, anticonvulsants, benzodiazepine, also acetylcholinesterase inhibitor, and memantine. When we think about prescribing a medication, there are some steps that we can address. The first one is, I believe, trying to see if there is an empiric treatment of pain that could be addressed first, because often it is undiagnosed and untreated, and it could give rise to some difficult behaviors, let's say resistiveness to care, for example. SSRI could be also a first step approach before using antipsychotics, and cholinesterase inhibitor and memantine are mostly used in prevention of some behavior, but they won't be efficacious for acute behavior that are very problematic. So why first thinking about pain? Because pain is common, as I've said, underdiagnosed and undertreated in dementia. Just by giving a routine acetaminophen regularly, it could be efficient. There was a paper a few years ago that tried to see if just by giving an algorithm of treatment of pain, they could decrease the agitation, and they stopped just at the acetaminophen level because it was decreasing the agitation on the ward just by doing that, and then go to other topical therapies or neuropathy associated treatment. SSRIs could be a first-line treatment, not only for anxiety and depressed mood, but also for irritability, lability, and there's some effectiveness demonstrated also in mild psychosis and agitation. So if there is like low-level psychotic symptoms with association with some anxiety, it could be a good way to address the problem in the first step, but they take a few weeks before having a clinical response. So if you are in an emergency with a patient very aggressive, it would not be the first choice. And with that medication, one needs to be careful with QTC augmentation, with citalopram and escitalopram, with hyponatremia and GI bleeding in patients which are fragile to that kind of complications. Antipsychotics, when we look at the specific indications, we know that it's for severe agitation and aggressiveness and severe psychotic symptoms. All studies in dementia have described a modest effect compared to placebo. And olanzapine, risperidone, and aripiprazole are the three ones that has been described as efficacious in that kind of problematic. There is an increased efficacy when symptoms are severe, which is great since it's the indication for prescribing it. Quetiapine is again and always the most used in clinical practice, but efficacy is not proven. Every randomized double-blind studies did not show that quetiapine was more efficient than placebo, but clinicians are under the impression that it gives less side effects, so they always they keep prescribing it, even though sedation and hypotension are often a problem with that molecule. Typical antipsychotics are less favorable because of their side effects profile, but they are still used in emergency cases mostly. You know that antipsychotics are associated with side effects according to their strength and dose, mostly extrapyramidal symptoms. Parkinsonism, in dementia, we see less of the tremor and more of the slowness of movement and rigidity. Akathisia that can be mistaken for agitation in patients that receive many doses of haloperidol in the emergency room ER, and they are worse and worse. One needs to think that maybe it's akathisia that is causing the increase in agitation. And tardive dyskinesia, in our cohort of patients, elderly patients, we see a 25% incidence after 1 year of treatment. So it needs to be also carefully looked for. And many others side effects, as you are aware of. I will put some emphasis on peripheral edema, because risperidone can give peripheral edema. Often clinicians think that it's related to cardiac dysfunction, and patients are given some Lasix, but one needs to think that it could be related to risperidone. And some weight gain and metabolic syndrome, less than in younger patients, but still. And one needs to refrain prescribing antipsychotic in the first intention in Parkinson's disease and Lewy body disease. They are also associated with increased risk, increased mortality. That has been demonstrated in retrospective studies, and is at the root of black box warning in Canada and in all around the world. We know also that prolonged treatment, more than 3 to 6 months, is associated with an increase in mortality risk. They are associated with increased cerebrovascular events also. So patients taking antipsychotics should be followed closely, and their antipsychotics indication should be reassessed regularly. We need to obtain an informed consent or substitute informed consent, and document that the indication was really there. Benzodiazepine, they are not a first line of treatment, even though they are very much prescribed in clinical practice. They have non-specific sedative and anxiolytic effects, and they are associated with many side effects in dementia patients. You know, the risk of falls, of excessive drowsiness, of worsening of cognitive disorder, delirium, paradoxical disinhibition, etc. If one needs to use them, even though it is suggested to choose a short-acting drug with a metabolic profile favorable to the elderly, like Ativan, lorazepam, or oxazepam, Serax. I will only say about cholinesterase inhibitor and memantine that they are used for preventing some BPSD. Usually when we prescribe them for the cholinesterase inhibitor in mild to moderate Alzheimer's disease, they are usually ineffective for severe agitation, aggressivity. The only exception would be that in Lewy body disease, they may improve BPSD, even psychotic symptoms in that specific disorder. And there are occasional worsening of BPSD when they are stopped. Specific problems, just a quick word about that. In frontotemporal dementia, it's another approach completely in pharmacological intervention. The only medication that has demonstrated a bit of efficacy are SSRIs and trazodone, because serotonin is usually has a role in, inhibiting the frontal lobe. So that's why they are used in that kind of problematic. And one needs to be aware that memantine and acetylcholinesterase inhibitor can worsen frontal behavior. So in those cases, it might be worth it to withdraw if prescribe those kinds of medication. And sometimes we are obligated to prescribe atypical antipsychotics because of severe aggressive disinhibition. Lastly, in Lewy body dementia or Parkinson's disease dementia, the first reflex is to lower dose or wean off of dopaminergic medication with the neurologist or the pharmacist if needed. First, if there's still some anticholinergic agents, they need to be withdrawn. Then the COMT inhibitor, dopamine agonist, to stay only with L-DOPA medication at the lowest dose possible. In Lewy body dementia, the first line of treatment is a cholinesterase inhibitor. And usually typical and atypical antipsychotics are contraindicated because of hypersensitivity from these patients, delirium, severe extrapyramidal effects, except for quetiapine, which has very little efficacy demonstrated in double-blind studies, but again is used for its more favorable side effects profile. Again, sedation and hypotension are often limiting. Clozapine is still the treatment of choices at low doses, and in at least 5 randomized control studies has been the gold standard to treat psychotic symptoms in those disorders, but they are usually a specialized care treatment because it needs close follow-up of hematologic and neurologic and cardiovascular side effects and risk. So that brings us to questions and the case discussion.